Hello, I'm Sylvester Turner, Mayor of Houston, Texas, and I am pleased to welcome you to this important training video. It is a video that was created for volunteer behavioral health professionals who want to assist their community in the event of a disaster that requires opening emergency disaster shelters. As many of you know, Houston faced a tremendous challenge at the end of August 2017 when Hurricane Harvey hit. As the storm approached, the city of Houston immediately started to set up our convention center as the city's main emergency disaster shelter. Displaced families and individuals were traumatized, not only by this abrupt, unwanted relocation, but they had no idea if they would have a home to return to when the storm waters subsided. We knew we had to have professionals in the shelter ready and prepared to meet whatever needs they might have. And we knew that emotional support would be crucial and behavioral health issues would be significant. In Houston, we are fortunate to have the network of behavioral health providers, an organization consisting of the leadership of the mental health and substance use disorder providers in our community. I called the network on Sunday evening, and within hours, the network was overseeing a team of volunteers from across the community, setting up the volunteer process, coordinating with the city, American Red Cross, and other emergency entities, and providing vital services. That one shelter served more than 10,000 Houstonians, and nearly 300 clinicians volunteered at the shelter 24 hours a day over the course of the first 12 days it was open. This video was created by the network members who led that emergency effort to share what they learned from the experience. Many of the individuals who wanted to volunteer had no training and service provision in a shelter situation, and precious time was spent getting them up to speed. It is the hope of the network and the city of Houston that this informational film will be a brief but solid orientation for behavioral health clinical volunteers who want to assist in an emergency shelter in any community in any disaster. Finally, I would just like to say that if you are watching this video, you are a person who is interested in volunteering your unique and much needed skills and time to assist your community's leadership in a time of tremendous crisis. I want to applaud you for your willingness to serve your neighbors and thank you on behalf of all the individuals and families that your work will reach. It's inevitable there will be another disaster someday, somewhere, that will test our communities to their core. But with people like you who step forward to be of help, we see our communities at their finest. Thank you for your service.
Okay, hi, I'm Sue Levin, and I'm currently the director of HGI Counseling, also known as the Houston Galveston Institute, and I'm glad to be here to talk to you a little bit about disaster behavioral health, also known as disaster mental health, in a shelter. So we want to thank you for your interest and also possibly volunteering to work with the network for behavioral health providers at one of Houston's shelters. Depending on the size of the disaster, there may be a variety of different shelters set up, different sizes and run by different organizations. It's helpful to identify where you would be most comfortable working, and that may have to do with the location, the size, and knowing who else will be on site during the response. I'm going to go over some of the basic information about how shelter responses are organized, and in particular, how large and mega shelter responses are organized. There are typically, and definitely in the case of the city of Houston, shelters that are run by the government, either city or county or a partnership. They use an incident command structure, which I'll describe in some detail. And they're run like small cities. The George R. Brown Convention Center and the Reliance Center have both been used as shelters during recent disasters, and they're set up fairly similarly, though there are also some differences, including which organizations are involved and what services are provided. It's important to be aware of the affiliations that you may have, whether it's through your work, faith organization, role in the community, etc., because that may be an avenue for volunteering that's separate from what we will cover. If your organization is part of the county or the city government, you will also have a different role if you are working with them. So our mega shelters are set up with the size and magnitude to function like a small city. They demand elements of government and community support that keep these cities safe and well and become multi-agency programs with venues that serve as central and important roles. Typically, no one agency or organization opens and operates these sites all by themselves. Mega shelters should be open under the administration of either the local or state government because running these shelter facilities requires coordination and cooperation of many different local and state agencies, including law enforcement, public health, social and human services, food services, and facilities management. If you're interested in what's involved in setting up a shelter, and the many services and resources that are typically represented, there's a link here from FEMA that will take you to a large handbook of information. You can see the index on the right. I've circled the chapters that may be of particular interest if you happen to be responsible for setting up and coordinating mental and behavioral health services. There's many, many resources online, and I certainly encourage you to investigate if you are interested in more details. So the way shelters operate and the National Incident Management System, which is known as NIMS, were all developed after 9/11, when the federal government created a law that required all jurisdictions from local to national governments to create disaster response plans. The video that you see on the screen is a YouTube that describes that, and we also have that listed as a link in our resource directory. The plan is constantly updated with all the latest information and best practices, and it's available for study and resources online at training.fema.gov/NIMS. NIMS offers a framework for how diverse public and private organizations can work together to offer coordinated and effective operations. The incident command is similar to a military command structure and is shown in the graphic. At the top is the command, made up of an incident commander, or they may be called a shelter commander, safety officers, public information officer, senior liaisons, and advisors. There are 4 areas or departments that operate under the command, and they report to the commander. That's operations, logistics, planning, and admin and finance. Each of these areas have different responsibilities and activities. Behavioral and spiritual health come under shelter operations, though there may be things that must be handled through logistics, planning, and finance. An example is setting up for volunteers to have access to electrical outlets, computers, phone chargers, for example. They all take logistics and potential expenses depending on your location. The behavioral and spiritual health program in a shelter will have a coordinator or director who will take care of things like setup and requisitioning of important items and materials. Each of the directors of these areas report to the shelter commander at specified meetings, usually twice a day or more at the beginning of an operation. Additionally, there may be meetings with other command personnel to create communication and provide feedback. Another example that may happen is when behavior and spiritual health volunteers notice that there's a problem with the layout of the food service. Because it's located close to the medical area, residents who are waiting in line for food may be witnessing injured and sick people who are upset and in crisis. This would be a concern that could be brought to the attention of the command center, and adjustments might be made to relocate the food service to another area. We are often asked what volunteers will do when they work in a shelter, and I can share a few stories. One of our volunteers had done a sweep of the floor, which is what we call walking through the shelter and taking the pulse of the residents to identify areas of need. She recognized that there was a group of senior citizens from an assisted living facility who were trying to get settled in the shelter. She spoke to their staff who had accompanied them and learned that many of them had medical needs, mobility challenges, and needed assistance with basic tasks. She reported their needs to the shift coordinator, who then made arrangements to relocate the group to a smaller nearby shelter for people with special needs. Another example happened with a volunteer who recognized that there were many children who were often waiting with their parents as they stood in line to get food. She offered to set up a coloring area near the food line to keep the children occupied. It took about a day to get supplies, tables, and chairs, but she was able to get them and a few others who volunteered to help out. Just as she was getting ready to invite the children to join her, someone arrived with $50 Walmart gift cards to distribute. This attracted lots of people who almost ended up in a fight as the distribution was not well organized. The volunteer quickly changed plans and reported feeling that it might have been a dangerous situation. Knowing the plans and activities in each area is something we always try to do, but occasionally things arise that we do not know about, and we have to be ready to adapt. For our purposes, we'll be going over the basic responsibilities of both the Behavioral and Spiritual Health Coordinator and a Disaster Behavioral Health Volunteer. The Volunteer Coordinator is part of a very thick hierarchical structure which governs the activities of the shelter. Volunteer behavioral and spiritual health providers in a shelter will likely be working in conjunction with several other agencies. Most recently at the George R. Brown, after Hurricane Harvey, the behavioral health area was staffed by medical providers, psychiatrists, psychiatric nurses, techs, and others from 3 different organizations. They worked in a clinic-like area where people arrived for medication refills and/or evaluations. The behavioral and spiritual health volunteers worked as feeders to the medical staff, identifying residents who might be in need of that level of care, and directing those who identified prescription needs, as well as offering resources and support to those who did not need medical services. Helping residents navigate the shelter and find the resources they needed, such as housing, application, religious services, etc., is part of making the community feel predictable and safe. Some questions to ask yourself when you think about possibly volunteering in a mega shelter. First is, am I comfortable working in a huge environment like that? This will involve a lot of walking back and forth, possibly 2 or 3 or 4 times a day. Or maybe you could be assigned to work at a desk in the shelter and therefore limit the amount that you have to be on your feet. Are you comfortable working with many people, many organizations, large spaces, and big noisy areas? And what are your unique skills that you're bringing to the table? What are the boundaries of your availability? And what are your cultural resources and limits? Do you speak more than one language? What else do you bring to the table? These are all helpful things to share when you volunteer your services. Thank you.
So now I'm going to be speaking about roles that volunteers might be asked to play in the mega shelter context. So in the mega shelter environment, the two things that I think are most important are having flexibility and attentiveness to the ways that situations change, the needs of evacuees change, and the resources that are available will change. In particular, be ready for new needs to emerge, and be clear about what you can and can't do, what your particular skill set is, what your background, what your experiences are, and also what you're willing to do and what you're not willing to do. The following are some standard roles that behavioral health volunteers may be asked to fill in a shelter. So the most important role that volunteers serve in a shelter environment, actually the most common role, is what we're calling evacuee contact, triage, and support. The most important intervention for the majority of evacuees is just going to be your calm and attentive presence to whatever their needs happen to be. Volunteers one of the most important roles that we play actually is just providing practical assistance. Where are the restrooms? Where's the food line? How do I connect with FEMA? Where's the medical area? How can I, find clothing? And orienting yourself to the shelter and where things are, and they often will change, particularly in the early days of a shelter opening. The location of resources may change, often within a day, or even within a period of a few hours. Check in with evacuees who look a little bit lost or overwhelmed, and you can understand that the shelter environment is going to be overwhelming for everyone, including the volunteers. Also, allow yourself to check in with them, and if they welcome your help, be there for them, and understand that they may not be ready for it, they may not want it, and so be ready also to give people space as it seems useful for them. One of the great benefits of having licensed mental health professionals in volunteering in a shelter is our capacity to evaluate, and this is where triage comes in, right? To evaluate maybe higher level needs that evacuees might have. Often, and we experienced this during Harvey, people were separated from their medications, for instance, and we can assist in getting people connected with the psychiatry teams and medical teams, and hopefully getting those prescriptions filled. We also can assist in just, discerning when evacuees might need more support, and from the psychiatric teams that are available on the floor. It can be confusing to access services, so be ready to accompany evacuees to the resources. Do not hesitate to engage with the law enforcement presence that will be there at the shelter if you're working with somebody who's actively decompensating or is a risk to himself or others. When we were working at the George R. Brown Convention Center during Harvey, the Harris Center's CERT team, and CERT stands for Crisis Intervention Response Team, was there. They worked very closely with the Houston Police Department and their mental health department in helping to defuse crises and to guide people to resources, or to guide them out of the shelter and into inpatient psychiatric services if it was needed. Keep this in mind. Behavioral health volunteers don't provide psychotherapy or counseling. That's not our role. Our role is to provide psychological first aid and really kind of informed assistance to people whose lives have been really radically disrupted. Our role is to help people establish agency, and that may be in just framing a very simple choice for someone. Do you want to go get some food, or would you like to go find your cot? That kind of simple choice allows them to begin to restore a sense of control over their situation, and I think is look for those kinds of small moments, those kinds of small interventions that you can make. And above all, don't force people to process. They might want to recount their narrative. Recounting their narrative can be very helpful, and simply sitting and allowing somebody to tell you their story is a wonderful use of time. but don't push too hard. Let them tell the story that they need to tell in their own time. I want to tell you about another role that we found useful, and this is maybe more applicable to a mega shelter like the George R. Brown Convention Center. Non-local shelter personnel, such as the American Red Cross, the U.S. Department of Public Health, FEMA, and other organizations who come in emergencies don't necessarily know what the local resources are. So we found that medical social workers were invaluable in working with the U.S. Public Health Department in discharge planning and helping to get people connected with resources outside of the convention center. So if you have specific experience, if you have specific knowledge about local resources, please let the leadership know of the volunteers so that they can connect you if there are opportunities like that. So now I want to speak briefly about the role of a shift leader. Usually this is a volunteer. This is somebody perhaps maybe walking into the shelter for the first time, but also perhaps maybe a returning volunteer who knows how the system works a little bit. And these are the kinds of tasks that the shift leader might be expected to fulfill. They manage the check-in and check-out of volunteers. They train and sort of orient volunteers to their roles. They make assignments for volunteers. They make sure that constant staffing is available at the behavioral health table in the shelter. Maintain records, including shift notes, so that we have some historical memory at the shelter. They collect identified needs from volunteers and work to meet them, and the needs are sort of ongoing. Also, the shift leader can provide a bit of initial processing for volunteers, and of course, the work will affect you in the shelter. The work will affect you, and the shift leader is there to keep an eye out for those volunteers who may simply need someone to talk to about what's going on, and that's that may be the only thing that people need. But they also may need more support after their experience there. You may encounter volunteers who are overwhelmed and are unable to finish their shift, and your role is to support them and to make sure that we do connect them with resources to process their experience. The shift leader also liaises with other important coordinators in the area. It's important to know who is the leader of the medical area, who is present in psychiatry. Also, often the City of Houston or whatever governmental agency is a partner in operating the shelter. It's important to know who those people are, and just to be checking in with them, because often that's how information is shared through the community at a shelter. And the last thing is that shift leaders tend to stay just a little bit later after their shift to brief the new shift leader on the current situation and things that may be changing. Lastly, I'll talk briefly about the volunteer coordinator, volunteer coordination. So this role is not filled typically by volunteers. They're filled by members of the network of behavioral health providers, such as myself and Sue and Ann and others. People typically who have leadership roles in organizations that are members of NBHP, also filled by staff of the network as well. Coordination generally has three domains: recruitment and scheduling, training, and site leadership. During our work at the George R. Brown, we had two general areas of coordination that were going on, and typically we didn't have the same person covering both bases. So the first was on-site leadership, and the leader was spending time coordinating with shelter leadership and moving in the George R. Brown. That often was happening on another floor of the shelter, so it was happening up on the third or fourth floor. So the coordinator is both trying to access resources, make sure that the volunteers on the floor have the resources they need, and that the needs of the evacuees are being communicated to the shelter leadership. They're also supporting the shift leader and the volunteers on the floor, and spend a bit of time, actually it can be a significant amount of time, they're on the floor working with the volunteers and the evacuees. The second role was off-site management, and volunteer coordination, off-site includes recruiting volunteers, helping to get them access to training materials, giving them information about what they might be expected to find when they get to the shelter, where to park, and how to move through the security process. This person also may be coordinating with agencies and providers around the region who also are, whether they're setting up shelters or looking for support from the behavioral health community. So there's a lot of that kind of higher level conversation going on outside of the shelter. And that concludes our section on the volunteer roles.
Hello, my name is Ann Way, and I'm the Clinical Director of Interfaith Samaritan Counseling Center. Today I want to talk to you about self-care for the caregivers, sustaining stamina in the face of suffering. Self-care is not selfish or self-indulgent. We cannot nurture others from a dry well. We need to take care of our own needs first so that we can, from our surplus and our abundance, nurture others. When we nurture others from a place of fullness, we feel renewed instead of taken advantage of. I love this quote from Jennifer Lorden. It tells us all about it's not bad to take care of yourself. It's a good thing. That's the only way we can do this work. This slide is about the stress, fight or flight response, which you've probably heard in every disaster video you've ever seen, and certainly about trauma. So I'm not going to go over it, but just know that as a volunteer, you are also subject to this same fight or flight response, and I'm going to help you manage that. So as a disaster volunteer caregiver, you may experience your own secondary vicarious trauma. Some people call it compassion fatigue, burnout, and this is a response to the suffering of others. Volunteers must prepare for their own emotional or spiritual storms, and knowing what may be experienced help us inoculate ourselves. Once we know what to expect, then we can indulge in self-care, self-compassion at all phases of the disaster response. My final words in this slide: stay present, self-aware, and reduce your stress. Preparing for the impact, and this impact is of your storm, not the event. So I'm going to give you some ideas about your volunteer survival kit. First of all, training in disaster response is essential. Lots and lots of training. Go to everything you can on how to respond. The next step is very particular to yourself. Define your internal safe room. This might be the calm, safe space that many of us use in EMDR, and there is a website that's enclosed in this slide that you can go to. There are YouTubes about this. Use them. The other thing, maintain healthy boundaries. Now that's something we all know as therapists, right? But we don't always do it, especially in a chaotic situation. Next, mobilize personal and professional resources. So whatever gets you through the day, use it. And there will be people all over who can help you, people that may not even be in your discipline, but have responded in these situations. And last on this slide is faith resources. We always admire or encourage our clients to utilize faith resources, but don't forget your own. So whatever it takes to get you through life events, use those. Some of the spiritual practices and stress reducers I've included on here, figure out what works for you. Soothing rituals, spiritual practices, meditation, prayer, music, mindfulness, exercise. Don't be afraid to stand up and move around, tapping. All these techniques, if that works for you, do it. If you're a yoga person, bring a mat. There's always a place to do that. You can get down there on the floor and stretch and do some yoga work. Stretching you can do anywhere. Artwork, bring a journal. Journal, draw pictures, do whatever helps you occupy your time and de-stress. Now, on site, it's so important that you are staying present for the clients and everyone else on the team. So you have to be well rested. Not always easy. Eat healthy, small meals, and hydrate. Move about, walk, stretch, just like we just said. And pass the baton when needed. When you're kind of done for the hour, get up and make sure you have coverage and take a walk. Do what you need. Ask for support. In this slide here, there's a beautiful picture that says, seek beauty in the depths of your anguish. So you got to do that. Even in a chaotic situation, you can seek beauty. In the shelter, which is probably where you'll be, you're going to have time to reflect. But remember, chaos is often the rule, not the exception. So it's often hard, but you must focus inward and find somewhere physically or emotionally and spiritually to laugh or cry. Often rhythmic sounds, nature sounds, even a metronome, which you can put on your phone, sometimes help kind of calm the spirit. You can dance, chant, sing, get a mindfulness application, anything that helps you get grounded. I always like to make sure that you realize that you are entering the sacred. We save space for clients and their sacred stories, but your sacred story is unfolding in real time. There is a sacredness in tears. They are not the mark of weakness, but of power. They speak more eloquently than 10,000 tongues. They are messengers of overwhelming grief and unspeakable love. Washington Irving. Unspeakable love. I want you to focus on that. Preparing for the path of this storm, which psychological and spiritual storms don't always go according to the plan. It's important, just like as a hurricane, clear out the psychological debris that could hit you. And you know what I'm talking about. What are your previous traumas, your known vulnerabilities? When you're in these situations, avoid the missiles flying at you. Resist taking on other stories. And I always say, have your evacuation plan in order. And by that, I mean, where do you go inside yourself? What's the route to an internal, safe, calm space? Don't try to outrun it, because the storms will catch up with you. Predictable paths of psychological storms. There are some predictable paths, even if we're very postmodern and we don't think there are. Experienced clinicians serve as your guides. Reach out to those guides as you need to. Trauma responses are varied, but well studied. So clinical responders do take time to self-reflect and self-correct. So if you find yourself in one of those situations, you have time to change the course. That's something that we can't do with a hurricane. So when you know, if you're tracking this storm, whatever it is, where are you? Assess first. What conditions favor a personal storm? What's your previous exposure to trauma? What's your professional and personal history and experience with trauma? Then there's the watch, just like we have a hurricane watch. You look for signs of distress developing, numbing of the self, self-medication,
the zombie effect. Then there's the warning. And the chart on this slide to the right, it shows the tragedy or event in the middle. How close to the target are you? That makes a difference. You know, how many levels back are you from this storm? Is your family evacuating right now while you're responding? That makes a difference. Have you had a recent death in your family? That makes a difference. So look for overt symptoms, depression, anxiety, panic, emotional paralysis, and some of these may have a sudden onset. I think it's important also to name your storm. Language matters. The helper's self-talk needs to be a talk of restoration. On here I say lean into love and self-compassion. We tell kids, use your words. So I say to you, use your words to restore dignity. Use a language of empowerment, of resilience, of hope. The power in naming. What's in a name? Quite a bit. Resist taking on stories of others. That's so easy to do when you're in these situations. And shed the names that others have given you in your life, in your family, in your friends, in your peers, that are limiting. One of mine is, oh, she's a redhead. Watch out, she's a redhead. So expand those names and don't allow those names to be on you when you're responding. You may have a very spiritual component to your name. Maybe one of the things you're experiencing is despair or hopelessness. And the name, this is very important, the name you give your storm comes from the volunteer clinician, from you, the one who suffers. So you name your storm, not other people. They don't get to name, oh, she's so emotional. You name it. It's a trigger, it may be an emotion, a negative belief, it could be a somatic complaint, you name it. And as your authentic story unfolds, it should resonate with soul and where the soul longs to be. It's an aspirational story. You're not there yet, but you will be. And part of it is reclaiming your story of resilience and hope. Remember to reserve kind words for yourself. We always give clients lots of ego-enhancing language. Reserve those for yourself. Intentional, positive self-talk. It says on the slide here, the golden rule, one kind word can change someone's entire day. Well, guess what? That can also be you. So change your day. Now, I talk a lot about the structure of a hurricane because I've grown up on the Gulf Coast and I know lots about hurricanes. But there's something I was always taught as a youngster. When you're in the eye of the storm, and I used to look around and look for actual eyes, it's important in this emotional or spiritual storm that you know some things about the eye. It can fool you. It appears the worst is over. Don't be lulled or seduced into the eye. Be prepared for the winds to change. Responses can come suddenly, unexpectedly, and not as predicted. Allow time for contemplation and reflection. Slow down. Remain curious. Find your calm, safe place. And in the aftermath, which there's an aftermath, both literally after a cleanup of storm debris, you have to clean up your own emotional, physical, and spiritual debris. You need to inventory what's been lost, what remains, what toxins should be disposed of. Some of those toxins might be the names that you've been given that just limit you too much. Toss them away. How has your emotional and spiritual terrain changed? And one I like the most is what treasures have been unearthed or recovered. You may have learned through this experience something that you had lost or didn't even know you had courage, a sense of humor, an ability to face adversity. On the slide it says, and most surprising of all, that I could carry it, that I could bear the unbearable. To me, that's a gem. That's something unearthed. So in review, self-compassion, positive self-talk prevents burnout, reduces secondary trauma, reduces emotional and physical stress, draws focus inward, so then you can refocus outward. Remember that disasters happen and adjust thinking accordingly. Accept the things you cannot change. Identify what keeps you safe and practice frequently. Avoid unnecessary stress, situations, and people. And you can do that at shelters, but that's just a good rule no matter where you are, even in the grocery store. There's always another aisle. And the last slide here is one I love. Martin Luther King says, we must build dikes of courage to hold back the flood of fear. That's you. That's all of the people that help respond, the caregivers. All of us together build dikes of courage. Thank you.
So now we're going to briefly explore the experience of evacuees. And I'm going to start with a couple of definitions, and I expect that this is probably a review for many of you. The first is simply the notion of stress. So stress is a state of mental or emotional strain or tension resulting from adverse or very demanding circumstances. A traumatic stressor is defined in the DSM-5 as exposure to death, to threatened death, to actual or threatened serious injury, or to actual or threatened sexual violence. And when there is a single traumatic stressor, 60 to 70% of individuals who are exposed to it will recover with minimal or no intervention. Now that's to a single stressor, and of course it becomes more complicated when there's more than one stressor, when there's a history of serious issues, whether they're environmental, physical, emotional. But for a single stressor, the majority of people will be able to return to normal. And the source for this information is the Israeli Trauma Coalition. So shelter work typically happens during the earliest period following a traumatic stressor, and diagnostically what we might refer to the experience of evacuees as is acute stress reaction. So an acute stress reaction is the experience that happens within a few days to a week of a traumatic stressor. Okay, so we all have acute stress reactions. This is a normal response to an abnormal situation. When we move from a week out to a month away from that traumatic stressor and symptoms are still present and the individual is having difficulty navigating their lives, we would consider diagnosing them with acute stress disorder. Okay, this is a DSM diagnosis. After a month is when we would consider diagnosing someone with post-traumatic stress disorder. So in the immediate aftermath of a traumatic stressor, what you might find in a shelter, you may find people who are dealing with PTSD, but they are dealing with PTSD from another experience, and the event that led them to the shelter may be triggering that post-traumatic stress disorder, but it's not yet diagnosable from the event itself. Once we get beyond a year, we're talking about chronic PTSD. Here's some thoughts again from the Israeli Trauma Coalition about intervening during a crisis. A person is most receptive to accepting help when they are experiencing a crisis. And even minimal intervention can have a powerful effect on people's behavior at this time. It may be difficult to find the solution to a crisis immediately after an event, and it's going to be dependent on environmental variables that are outside of the evacuee's control for the most part. It's useful to remember that coping skills are things that are not simply innate, though of course they are innate in some people, or they're more present in some people than in others, but they can be learned, and there are opportunities to teach them in the shelter context. Interventions that we make, the simple interventions that we make, they don't have to be made by a clinician. They can actually also be made by a parent or a significant person in the evacuee's life. And I said this a moment ago, but I want to underline it. For the majority of people who are exposed to disaster, an acute stress response is a normal reaction to an abnormal situation. And to help them to understand that this is a normal reaction may be one of the most supportive things that you can do. It's important that intervention take place in close proximity to the time and, to the extent that it's possible, to the place of the traumatic event. The focus is on the here and now, as opposed to past experiences that the individual may have had. And in most cases, the intervention is very brief, and certainly in the shelter context, the interventions that we make are brief. So we want to talk a bit about working with homeless people. And I want to thank my colleagues at Search here in town, as well as at the Star of Hope, who have helped us to collect and refine our thoughts about working with homeless people. So, the population of a mega shelter changes over time. Right after Hurricane Harvey in the George R. Brown Convention Center, people who had huge social networks and many material resources were swept into the shelter, along with people who, prior to the hurricane, had very little resources and perhaps a very limited social network to rely on. After a few days, people who had resources and community networks left. And so those who remained typically had the most difficulty establishing new residences, may well have been homeless before the storm, or marginally housed. While they may not have lost homes in the disaster, the people who are homeless can still be displaced and experience severe disruption in their routine and their ability to access resources. Many of the resources were closed or unavailable for weeks and weeks after the storm. Some general guidelines when you encounter homeless people. The first is that rapport and relationship building are absolutely vital, and just validating the experiences of the people that you encounter and listening can be very powerful. Many homeless people have significant trauma histories, they have high ACE scores, and they have challenges with trust and attachment, which may mean that they're going to have challenges trusting you and trusting other shelter personnel who are trying to help them. So meet the individual where they are, and understand that housing may not be their first priority. Their first priority may be immediate basic needs. Your role is not to be a gatekeeper to resources. You're just there to support them however they need it and help let them define how they need it. Pay attention to your boundaries when working with anybody in a shelter context. Pay particular attention in working with homeless people. Countertransference and self-care are particularly important. Countertransference, for those of us who are maybe not as psychodynamically oriented, or just simply the sum total of reactions that we have, experiences that we have as we come into contact with the experiences of others. When we are in touch with those who have been traumatized, our own experiences of trauma and woundedness may be touched as well, and it's important to keep that in mind. Know ahead of time what you can and cannot do to help, and be very transparent about your role and its limits. Throughout shelter work and also with homeless people, don't expect them to validate your role as a helper. They may not be able to even say thank you. to you. They are in a great state of turmoil and shock, and they may simply turn to what is the next step for them, or what may give them comfort. You are not responsible for fixing anyone. Be able to recognize and address, as we've said at an earlier point in the video, it's wonderful to have behavioral health volunteers on site in a shelter because we're better equipped to assess psychosis, suicidal ideation, homicidal ideation, and acute mental health crises that, as we've said, can be addressed by others at the shelter, including law enforcement and the CERT team and others. Generally, maladaptive behavior is not within the scope of your work. And if somebody is resistant to being helped, don't feel that you need to impose it on them in any way. So, a few more thoughts. If you're encountering and working with a homeless person, start with validation. Listen to them and their experience. Understand that they may need some help with emotional regulation in this situation. And as you listen, pay attention to any potential goals that might emerge, and help the client to identify and focus on those. And then, steps that might follow from that to achieve those goals. It is common for mental health professionals who are not accustomed to working with homeless people to be overwhelmed by the scope of the needs. So for your own care, as well as the effectiveness of your work, focus in on just one or two problems that you can help them to address. It is possible for a brief intervention to be used with some homeless individuals. So such things as helping them with stress reduction, positive coping, relapse prevention, and attending to substance abuse issues, solution-focused program solving, and some basic psychoeducation can also be very helpful to these individuals.
So to wrap up, we hope you found some important pieces of information that will help you get oriented if and when you decide to volunteer as a behavioral health provider in a shelter. We've covered some basics about shelter functioning, the needs of shelter residents, the roles of behavioral health volunteers, the relationships and organizations of various shelter medical and clinical teams, self-care for behavioral health volunteers, and special issues such as homelessness and acute trauma. The links and resources we mentioned in the video can be found on the NBHP webpage that's devoted to disaster behavioral health resources. Please visit it at nbhp.org using the URL that you see on the screen. This resource will be updated on a regular basis, and it's available to you at any time. We hope that you'll check back periodically to see what is new, and we'll share the information with people you know who may be interested in volunteering. And finally, thank you for all that you do to make and keep our community healthy and strong before, during, and after times of trouble. Thank you so much for watching this presentation, which is a production of the Network of Behavioral Health Providers of Houston. It was made possible by a grant from the Houston Endowment. Here you will find a list of works cited during the presentation, and you can find other resources at our website, www.nbhp.org. Special thanks to our faculty, to Brandon Carter of NBHP, and to the Young Center for producing this video presentation.